Welcome to this special session on health issues, specifically organized to address the challenges relating to COVID-19 in Central Asia and especially here in Kazakhstan. So we have lined up a panel of international experts who are at the heart of contributing to policies working with WHO, international health authorities from both overseas and here in Kazakhstan and Central Asia. I will first start off with my session to give you an overview of the situation here in Central Asia and Kazakhstan. Thank you. Healthcare challenges and COVID-19 in Central Asia. I will give an overview of the historical background and the fact that we had the Alma-Ata Declaration from WHO that has been renewed into the Astana Declaration 2 years ago to give the economic case for primary healthcare. Now, how is that going to be consistent with our efforts here to control COVID-19 in Kazakhstan? So I would give you a little briefing about the health issues in transitional economies, covering both Kazakhstan and the context of Central Asia. And then we'll move on to ask the questions about COVID-19 and emerging diseases in Central Asia before we talk about the future issues here in Central Asia. Now, to give you a historical background, the WHO first held an international conference in 1978 where they issued the Alma-Ata Declaration on Primary Healthcare. It was held here in modern Almaty 42 years ago. So 40 years later, in the year 2018, 2 years ago, WHO organized a global conference on primary healthcare in Astana then towards a renewed commitment to strengthen primary healthcare in order to achieve universal health coverage and the SDGs. Now, the Astana Declaration on Primary Healthcare from Alma-Ata towards universal health coverage and the Sustainable Development Goals, which is the title of the conference, was issued at this particular conference to address the new challenges in primary healthcare, which included the financing and the quality of care. A year later, the Astana Declaration was presented at a very high-level UN meeting where it was accepted at the 74th session of the UN General Assembly. Now, the Astana Declaration on Primary Healthcare essentially said that we are committed to, one, to make bold political choices for health across all sectors, two, to build sustainable primary healthcare, three, to empower individuals and communities, and four, to align stakeholders to support national policies, strategies, and plans. Now, from Alma-Ata to Astana, like I said earlier, Alma-Ata Declaration enunciating all these principles were listed in 1978, which led to WHO's Health for All by the year 2000. So 2000 has come and gone. What has happened since then? The original Alma-Ata Declaration defined what primary healthcare was. It went into the elements of primary healthcare, and then there was a lot of debate to define the basic packages and the minimum levels of primary healthcare that each country should aim for, which then led to the UN Millennium Development Goals, MDGs, around the year 2000. And then beyond that, from 2015 onwards, it went on to define and change Millennium Goals into the SDGs, or Sustainable Development Goals, building upon the original WHO commission in 2001 chaired by Jeffrey Sachs on macroeconomics and health. Not to be outdone, in the year 2008, the social scientists came along with this report on the social determinants of care, which then led on to more and more concepts of universal health care and the SDGs. So in the year 2018, the Astana Declaration was declared to reaffirm the fundamentals of primary health care as enunciated in the Alma-Ata Declaration, but to address two fundamental issues that were raised. How are you going to pay for primary health care? So financing primary health care was included in the discussion, and including the other factor, which is the quality of primary health care. So in the Astana Declaration, we also address raising the quality of primary health care. So the economic case for primary health care was supported by basically a lot of WHO technical reports and studies to build the economic case for primary health care, where they did a scoping review to look at health outcomes, to compare health systems efficiencies and health equities, and to justify why primary health care should be used, since it was the most efficient, cost-effective, and equitable strategy to improve health outcomes and to advance universal health coverage. But it also acknowledged that we need further research to determine whether aspects of primary health care to improve these health outcomes, the health system's efficiency, and the health equity should be further done. In order to identify barriers and enablers for implementation, and also to be able to strengthen those systems and to help policymakers to target the investments. Now, most of you may have seen this cube when the primary healthcare agenda got enlarged with SDGs into the definition of universal health coverage. What you see is this dark blue cube where the current healthcare financing and delivery of primary healthcare seems to be located, in a much bigger cube where you have to address at least three aspects. Number one, you have to ask the question on population, who is covered? Because currently your healthcare system only covers what is in the blue cube, but there is a space to extend it to the non-covered. The next question is, what kind of services are covered? And you may have to include other services that are currently not within the national healthcare systems. And the third is to be able to reduce the cost sharing of the fees or the gaps in between how you're going to pay for the healthcare. So that the concept of universal health coverage is not just delivery, but it's also financing in order to be able to fill up this whole vacuum from the current limited national health services and system. Now, I was here about 2 years ago. The economic case for healthcare was discussed quite thoroughly, and we even moved on to a subpopulation group which was not sufficiently covered. It was felt that with population changes such as migration, people are moving from your country to another country, or from other countries into your country. So who is going to pay for the primary healthcare of these migrants? So we had a thorough discussion, and this seems to be a major shortcoming. Now, as far as Central Asia is concerned, as you know, we have undergone various kind of health sector reforms ever since Glasnost and Perestroika. So in the post-Soviet era, there seems to be hemmed in the bureaucratic legacy where the emphasis was on specialization and on hospital practice. And with the liberalization in the markets, there seems to be some contradiction in the policies towards more privatization and more decentralization versus what actually healthcare systems are delivering and financing. So we need a lot of health sector reforms, but the reforms are limited mainly to the financing options, such as ways of paying for healthcare, like social health insurance. But it must be very clear that the social health insurance seems to be a continuation of the old central allocations of central taxation from the top down. So there is a misalignment between the incentive structures and the way you pay with the kind of quality of care which is differentiated. And the money that's coming in to Central Asia from outside in form of foreign assistance is not uniform. It seems to reflect the degree of openness and liberalization of individual countries, and they need to be able to separate development programs that are affecting the social determinants of health versus the actual reforms in the health system. And people often tend to confuse or conflate the two. So where do we go from here in Central Asia? I think future health policies currently must go beyond the current mix of public and private delivery and financing to evolve new forms which are to reorganize the public hospitals and the service delivery to respond not only to the competitive private healthcare markets and growing trends in medical tourism. But this healthcare system are so disparate because they can range from dominant tax financing to the new social health insurance, but still having very high out-of-pocket payments. There may be a push towards wider universal coverage of the population, but more needs to be done to ensure access for the poor. So private financing is increasing relative to government expenditure, but these new forms of health financing could be better restructured in response to future shifts in the demography as well as the age dependency and the epidemiological needs. There's now potential for greater private-public participation with economic growth through the regional integration of the region and with international collaboration. So despite the division where Kazakhstan and Central Asia seems to be divided up and coming under different development agencies, all these need to be integrated together for the region. Now, what about the future? I can see that for the rest of Asia, where there is a very rapid population aging with economic development, you end up with a lot of aging issues. Professor Goh, myself, and another colleague, last year we went through almost 10 years of studies to come up with this comprehensive study of aging in Asia. But what we have missed since it was released last year was the impact of COVID. So how is COVID-19 going to affect future aging in Asia? So as in summary, for Kazakhstan and Central Asia, we need to do more comparative health systems and policies. We have to then look at the common origin of having the Soviet system, now moving on to a post-Soviet long-term development, what's going to happen. We have to also study the impact of many of these foreign assistance and the influences and policy influences on the respective health system. Then finally, we also have to look at the impact of the WHO declaration and the UN SDGs, which everybody have subscribed, and to make it consistent with our current policies. So what about the impact of new emerging diseases like COVID-19 on our policy? How will it affect the peoples here in Central Asia? Well, just early this morning, I had a chance to include some of these statistics for Kazakhstan. And I noticed that actually, if you look at the indicators, these are from WHO, some of them are a little dated. It needs to be updated. But there's this trend towards chronic diseases and rapid aging of the population, where Kazakhstan seems to have done very well. We are ranked first in the CIS countries, but overall, we are still ranked 51st among all countries. But you seem to be higher than even Russia and the other CIS countries here. So where do we go from here? We have the Astana Declaration. We have your own local reforms here. So it seems to me that we have to reconcile all this. So our objective is the one, continue your national dense solid healthcare reforms in Kazakhstan to aspire to have higher and higher health status. We need to revise the implementation of social health insurance, where you had a pilot last year to implement it. And so we have to revise to include primary healthcare, to orientate primary healthcare as enunciated in the Astana Declaration. You have to integrate the primary healthcare towards health promotion and disease prevention, and not just to finance the healthcare needs alone. You will have to then go upstream to promote health and disease prevention as well. And last but not least, you have to balance this role of financing for future healthcare needs. How you cope with the future chronic disease needs with some of these novel and re-emerging disease needs. So on that note, I'd like to end, and I'll move on to the second speaker.